Greetings. My name is Dave Shear. I'm an orthopedic trauma surgeon at UCSF, and I work with both IGOT and Sign Fracture Care International. Very excited to be collaborating on this webinar with HGOC on bone transport. This lecture is going to be about the principles of creating a stable frame, which is very important in cases of bone defects where you're going to be using external fixation to address the defect. Our learning objectives first are to really talk about this overall concept of stability of the frame as being a function of the frame configuration combined with the fixation that we add to it. The frame configuration is really comprised of the rings that we choose and then the rods connecting them. The fixation is the wires and half pins that we then connect to the frame that join that frame to the bone. And then lastly, we'll talk briefly about safe zones, which are important to consider when replacing our fixation. How stable is stable enough? Well, it really is critical, obviously, that the frame lasts the duration of healing. When we're talking about bone transports, these frames are almost always on for at least 6 months, and in many cases on for a year. So they really need to be very stable to last that long. And because they're on so long, we don't want to make these patients non-weight bearing for a year. So they also need to be stable enough to allow for weight bearing. So they're quite different than the frames that we use in acute trauma that might be just temporizing a limb for a few weeks. These ones need to be much more robust and much more stable. There are a lot of factors that go specifically into how stable is stable enough. There are patient factors like the patient's weight and bone quality, and obviously treatment factors like how long the frame is going to have to be on that all factor in. And as a general rule of thumb, more stable is better. You're never going to regret having a frame that's a little bit more stable as opposed to one that's not stable enough. So again, the overall concept is that stability is a function of the frame configuration and then the fixation that we add to the frame. The frame in general is the rings, and then the typically threaded rods, or if you're using a hexapod, it could be struts. For this, I'll focus more on threaded rods. So for the rings themselves, you do have some choices here. The first is just whether you use a complete full ring or whether you're using complete rings. In general, the full rings are much more stable, but soft tissues sometimes don't allow their use. Good examples would be around the knee, where we often use a 2/3 ring in order to allow knee flexion, or in the thigh, particularly in the proximal thigh, may need to use arches because of soft tissue considerations. But our goal in general is to use the most complete ring possible. In terms of the size of the ring, we generally want to choose the smallest possible ring. The smaller the ring is, the more stable it is. It's about a 70% increase in stiffness with a 2 centimeter smaller diameter ring. So smaller is better in this case. But we have to consider soft tissues. It's not just the bone. So we have to have adequate soft tissue clearance. Typically 2 centimeters is a good rule of thumb. Posteriorly, may want to go for 3 centimeters because there's often swelling that occurs. So the smallest possible ring while allowing adequate soft tissue clearance is the goal. As I mentioned, the rings can be connected by threaded rods. Some cases, struts are used, particularly in deformity cases and things like that. But for the purposes of bone transport, I'll just focus on threaded rods. You can increase the stability by increasing the number of rods and increasing their diameter. But the truth is the threaded rod diameter is fairly well standardized across most manufacturers, are almost all 6 millimeter rods. And with the standard 6 millimeter rod diameter, usually for threaded rods, provides for sufficient stiffness in these cases, and there's really diminishing to returns with adding more threaded rods. It's not the weakest link, so to speak. But a variable that I think is more important that does come into play very frequently is the idea of a ring block. So this is a tool that you can use to increase the stability. A ring block is when you have more than one ring on the same segment of bone. So, like in this clinical photo, there's a deformity, and there's a ring block above the deformity, which is the two rings above, and then a ring block below. So each bone segment, the proximal bone segment and the distal bone segment, has two rings. And by placing two rings on each segment, we get a much more stable frame than if it was just a single ring. In a bone transport case, you actually have three segments. You have a proximal segment, a distal segment, and then you also have the transport segment, which is shown here in yellow. So a minimum would be three rings. But if we want to increase stability, you might add ring blocks on the proximal and the distal segments, like it's shown in this schematic. And the clinical example here is very similar. So here you see there's a ring block above the corticotomy and a ring block in the distal segment below the bone defect. And so that increases the stability of those two segments. So those are the frame configuration considerations that you can think about. And then the next important variable is going to be the fixation that you choose, which are wires and half pins. Wires are sort of the traditional Lozara fixation. They tend to come standard as 1.8 millimeters in diameter. They work really well when you have short bone segments, particularly if the bone quality is poor or in metaphyseal bone. They often are preferable to half pins. There are a number of things you can do to increase the stability of the frame. The first, which is very intuitive, is just to increase the number of wires. Here's just a case example where you can very short segment of bone. You put a very large number of wires, and this is helpful if bone quality is poor and the segment is short, and you really want to maximize stability. Tension is also critical. You can use the example of this tightrope walker. You can imagine if there was no tension on that cable, that it would be very unstable. But when you put tension on it, it almost becomes like a rigid beam. It becomes quite a bit more stable. And this is similar to what we do with ring fixators. We apply tension to the wire using a wire tensioner. Ideally, it's one of these calibrated tensioners, which allows you to dial the exact amount of tension. The amount of tension you should use depends on what the bone can tolerate and then what the ring can tolerate. What the bone can tolerate depends. So in the diaphysis, usually it can go up to 130 kilograms. In the metaphysis, there's really diminishing returns when you go beyond about 110. The wire can cut through the bone, and you really don't get much added stability by adding more tension. The other considerations are what can the ring tolerate. So if you're using an incomplete ring, like the 2/3 ring around the knee, for example, you can't place as much tension because there's deflection of the ring. So you usually would decrease your tension by 25% or so if the ring's not been completed. There are some alternative methods if you don't have a calibrated tensioner. The classic would be the Russian method, which is where you just using two wrenches, you partially tighten the wire to the fixation bolt, and then you rotate the wire. About 90 degrees of tension is roughly a tension of 100, but that's obviously very experiential. Requires a lot of experience to be able to dial that in appropriately. The other option is to use a handheld rivet gun. There's been some studies of this at Sign of using these. These can be purchased at a hardware store for about $5. They can generate upwards of 100 kilograms of tension with one full squeeze of the rivet gun. So this can be used, but again, neither is calibrated, so it requires some experience to be able to ensure that you're getting the correct tension. In terms of diameter, there's really not a lot of flexibility here. 1.8 millimeters is the workhorse. Certainly, if you're in a upper extremity or children, you might want to consider using the 1.5 millimeter diameter. Crossing angle is also really important. From an optimal biomechanical perspective, 90 degrees is ideal. but soft tissues very rarely allow that. So what's shown in the bottom angle is a 60-degree crossing angle, which still is considered ideal and significantly increases stability while still accommodating the soft tissues. Olive wires are also another way to increase stability. So these are the image here. It's like a little bulbous portion of the wire. And what that does, if you place the wire against the bone, is it prevents the bone from sliding over the wire. And if we go back a slide to this picture, you can see with crossed olive wires, so you have the olive on each side of the bone on that bottom image. That is really optimal because that's going to prevent the bone from sliding in either direction. So a good crossing angle and crossed olive wires gives really stable fixation. Drop wires are another technique that you can use. If you're trying to use a single ring and get increased stability, you can use these posts to build up away from the ring and spread your fixation out with your wire. The downside of these, as you can imagine, is with the post, the longer the post is, the less tension you can put because it'll deflect the post as you apply more tension. So your tension may only be able to get up to 50 or 60 instead of the 100 or 130 that you might get if you're directly off of a full ring. But it does allow you to spread your fixation out. You can see where typically you only are able to place wires right along the ring. With the drop wire, you can spread that fixation out a little bit. What about half pins? Well, they do provide some advantages. They definitely are often better tolerated by patients and cause less skin problems. They work really well in diaphyseal bone, where you get good bicortical fixation. And they work in the metaphysis as well, but it is important that that metaphyseal bone be healthy. What can we do to increase stability with half pins? Well, the first is choose an optimal diameter. So, typically in the lower extremity using 5 mm pins. You can, in larger patients, use 6 mm pins in the tibia or definitely in the femur. But as a general rule of thumb, if you remember 5 mm, that works for most patients in the femur, tibia, and humerus, and then certainly smaller pins in the forearm. It is important. A 5 mm versus a 4 mm pin is about a twofold difference in the overall stiffness. So we do want to try to optimize and use larger pins where we can. Similar to wires, we want to get increase the angle between the pins off the ring. So you don't want them all on the same plane. This is why uniplanar fixators are inferior to ring fixators when it comes to stability, because we can place these pins at a 90-degree angle. And the nice thing with half pins is that we can achieve this very commonly 90-degree angle because the soft tissues will allow it. In the classic mid tibia region, you can do an anterior to posterior and a medial to lateral pin like this. Get good spread and good bicortical fixation while respecting safe zones. Spread of pins is also important. The concept I always think of is like holding a broomstick. If you try to hold a broom with your hands right next to each other, you have very little control over the broomstick. But if you spread your hands out, you have really good control. That's the same way with our fixation on a ring fixator. So here's just a schematic. You see on the left, the pins are relatively close together. And just by using a longer Rancho cube on the right image, we've spread that bottom pin out further and gotten better control over that segment. So we want to get our fixation spread out on each bone segment as much as possible. This can be done also by angling the pin. There are some simple ways to angle a pin by building the Rancho cube off of a hinge, or there's a number of different ways with the different Ilizarov components to create this angled pin, but it can really significantly add stability when you have a long segment like this. So how many points of fixation is adequate? Generally, we want to go for a minimum of 3 points of fixation per segment, but I would say ideal is 4. A very common thing would be to use 3 half pins plus a wire. With 4 fixation points, if you run into an issue and follow up, the patient comes to clinic and has a pin site infection or the wire is really irritating, you can just remove it in clinic and avoid a return trip to the operating room. Whereas if you have 3 points of fixation and you have an issue, you're probably going to have to go back to the OR and add another point of fixation before you can remove one. There are certainly some situations where you have really poor bone quality or a really short segment where you may even have to go 5 points of fixation with wires or something like that. But these are good rules of thumb. So I won't go really deep on this, but it's important to know the safe zones. There's this classic Atlas, Ilazar of Atlas that goes through all the safe zones for every bone in the body and all the different cross sections. This is just an example of one for the tibia showing the safe half pin and wire placements across the different levels of the tibia. If you're new to this, it's not a bad idea to, tape this up in the operating room to make sure that you're not going to be hitting any neurovascular structures with your placements. So, take home messages. Just remember the overall stability of your frame is a function of the frame configuration and the fixation that you add to it. The frame configuration should be optimized using the smallest rings and the most complete rings that the soft tissues will allow. Try to create ring blocks whenever possible to increase the stability. And then in terms of fixation, we want to shoot for at least 3 and ideally 4 points of fixation per segment. Wires are optimal for the short metaphyseal segment, and half pins work best in the diaphysis. Remember all those factors that we can use to increase the stability, spreading the fixation out, trying to create bigger crossing angles between the fixation whenever possible, but within the bounds of the safe zone. So make sure you understand the safe zone for the bone that you're applying the frame to so that we don't inadvertently cause injury to neurovascular structures. So that's all I have. Thank you so much. Thank you to Kieran and the HGOC team for putting together this webinar. And please don't hesitate to reach out to me if you have any questions about the talk or bone transport or generally.